So I hope that you will bring some of the passion, a little bit of the salt that we saw in our earlier discussions, because that is going to be critical for the next 30 minutes. I hope you felt, I know I have, and I hope you've seen and heard that the National Forum is at truly an inflection point. So we had a board meeting yesterday, and we talked about that, and we talked about the Value and Access Initiative that you've heard a bit about, and how we're seeing true impact from that. We talked about Move with the Mayor, and how thanks to, say, Mayor Schmidt and the Green Bay program, we have some data that we can really start pointing to say there's impact there. So, and then we have discussions like what are happening today. I mean, I have to say I've been coming to these meetings for a good number of years, and every year people are very engaged, but this one, I think we've hit it. This was extreme engagement in all the right ways, and it's been wonderful. And so now where we are is we are looking at National Forum going into the 2020s, and the question becomes, now that we're at this point, where do we go from here? And we started talking a little bit about that as a board yesterday, and we'll do a lot more of that and with the staff, et cetera. But what the most important thing to do is, of course, to talk to our members, because you are the National Forum. You define what is happening today, defines exactly what we're here for. And that is to convene and collaborate to do better, to I was thinking of, the term umami. It's that robust flavor. I don't know if those of you aren't familiar, but it's a lot used in Asian food, but it's what's that extra something that we can add as the National Forum to all of the efforts that we're all doing individually. And so what we thought we'd like to do today is you have some sheets on your table. We'd really like to ask that you start to help us with our planning process as we move into the 2020s on where do we go from here. So the question becomes, how do we turn some of the successes that you've heard today into something bigger? How do we scale? How do we take the impact of our initiatives to date and make bigger impact, make them a bigger deal? And importantly, is really about where can we add value. There's a lot of organizations in this room, who, as well as those who aren't in this room but are members. You're doing a lot of great things. So what's left? Where are those gaps? So we want to use the next 30 minutes. So a nice focused brainstorm, but we've got really good energy to answer the questions that you have on your sheet, and they all ladder up to how does the National Forum help increase and accelerate your impact. So I will just touch on the questions. We'd like to spend a little time on each of them. And the first one is, as you're thinking about your organization's goals, what's the biggest reach, or are you a little worried about anything? Is there anything where you're saying, I don't know, we're going to reach that goal, but if we just had that little extra help or a little extra brain power or whatever, maybe we could. And then the second question is, where are the gaps? So you're doing X. So what do you wish you could do? What's Y that you think you would love to do if you just had a bit more bandwidth per se? So how can the National Forum maybe fill those gaps? And please be aspirational. We're a small organization, but that doesn't have to mean anything, because we have a lot of power in this room to work together. So please think very hard about where are those real gaps, and we'd like to help fill those. And then finally, and this should be, I hope, a pretty quick question, but the end is, who is not in this room, who's not a National Forum member who should be, and why is that? What could they bring to the table? So if there's anyone you didn't meet today or that you haven't worked with as part of the National Forum, but you think that they would add value, then throw those into your paper. And if someone could be a scribe at each table, we'll spend the last 10 minutes sharing some of the things that you've come up with. And then we'll compile all of your answers and your thoughts into a document. We'll organize it, and we'll put it out as a post-meeting piece of content that everyone can take a look at and get inspired by. And then we'll be using those thoughts as we plan as an organization and as a board. So You have about, well, I've taken a little of your time, but we'll go till about 2:35, so you have about 30 minutes. If you could just give a little bit of thought to each of those questions, and then I'll come back up and we will share a bit before John gives us our closing. So thank you in advance for your energy and your thinking. Okay, if we could wrap up everyone's discussion, so we have just a few minutes so that people could share a few of your ideas. And we'd ask that whoever has taken the notes, if you want to just leave the sheet on the table when you're done, and I hope we can read them. Oh my. Okay, we'll make Debbie translate that one. So if everyone could, so make sure to leave your notes behind so that we can capture that into one larger document. And so I'd like to spend the next 5 to 10 minutes to let folks share. If you could pick one thing from your idea sheet that you'd like to share with others that you thought where you landed on perhaps where National Forum could fill some gaps, what we might think about as we move to the 2020s. So where's our microphone? Okay, we have some volunteers. Where's our microphone? Okay. Let's start with Fred. Oh, we're starting with Warren. Okay. Or Fred.
Fred is so shy. The problem with sitting with the chair is you get voluntold. Okay, so I was voluntold that I would share with you a concern that we brought up here was about bias towards access to care-related issues. There are providers who provide competent care, assessment, and care that plans may not necessarily want to include in covering the payments for them. Often they don't include them in their networks. So it creates a significant problem. Here's an example. My daughter was in New Orleans, Louisiana. She was properly insured. There was not a health care provider on any of the plans that was within the city of New Orleans. She had to leave the city of New Orleans to get access to care. One of the things that the general deals with the DHA, the Defense Health Agency, and TRICARE. This is a nationwide program. If a service member's dependent is not near a military treatment facility, the TRICARE network in that area may not have included a provider or an assessment capability. So they have to travel distances to get that. So we feel that when you've got underrepresented populations that have complex issues to deal with, and plans and insurers are selective about who they allow to provide the services, it complicates issues and it really heightens the opportunity for bad outcomes with heart disease.
And your point, I think part of the discussion was that there may be community providers, yes, say a community hospital or anyone that's lesser known than a very high level facility, yes, that might be perfectly good at providing a certain service, a treatment, a diagnosis, but they won't be covered because they are not, perhaps high enough on the echelon. Yes. Right. And so to increase community level access, if we really are serious about taking this to the communities, we need to address the issue of institutional bias and how do we create more access by sort of spreading the wealth, if you will, or changing the way we judge or designate facilities. And so perhaps the National Forum puts a panel together, thinks about bringing the stakeholders together to address an issue such as that. Great. Fred?
What you just said is exactly what I had written down here just a few seconds earlier. So I think we are experiencing an alignment initiative in real time. So the overall point that we made here at this table was to align all of the National Forum members to develop a program to treat upstream health issues, to attenuate downstream issues. I was very impressed with Dr. Schell's comment in terms of what happens in the military when you're out of shape, and how to attenuate that by having health problems addressed early on. And since we are in different organizations, the National Park Service with Diane, one of the REACH issues is to better integrate into healthcare delivery systems the National Park Service and to create a skills-based program to have public health service staff serve in the National Park Service. National Park Service is key to a lot of health-related initiatives. Now, in terms of the Minneapolis Heart Institute Foundation with Rebecca, one of the reach issues is to disseminate the research outcome to a greater spectrum of stakeholders compared to simply primary care physicians, to educate the population more in general. With Jay's Medicine and Public Health Initiative, he's looking for other organizations that combine functions of research, teachings, and service. He's looking for concordance, and one of the initiatives is a collaboration between his organization and the National Park Service. Now, with the Food and Drug Administration, I've always been an advocate of medication adherence. That is not a secret. And I'm looking to develop strategies, regulatory strategies, to enhance medication adherence and attenuate health disparity. And one of the ideas that we've been always thinking about is to create incentives for example, patent extension to drug companies if they incorporate into their development strategy an adherence protocol post-approval. This could be patient engagement, working with payers to so-called pay the patients to take their drugs, engage human behavior to optimize medication adherence. And this is sort of the analogy of a risk evaluation mitigation strategy. We can call this an adherence enhancement strategy as part of the drug development process, as well as to encourage or require enrollment of African Americans, women, or Hispanic populations in clinical trials to get better representation in the United States. That, of course, that impacts where you do the trial as part of the clinical drug development strategy, but there should be incentives for that sort of thing. So, in bottom line is that we have a lot of organizations within the National Forum, and we should convene a panel of cross-organizational ideas to develop an alignment strategy to incorporate regulatory policies, payers, providers, et cetera, to maintain patient engagement, and that somehow leads to adherence and a decrease in stroke and heart attacks. So that's how we look at it.
So just a small goal is what you're saying. Just small. I hear you. Thank you. Who else? We have time for maybe two more ideas. Have one.
So we three spoke from the National Association of Chronic Disease Directors' perspective and thinking about what may be a nice way to sort of inject some more energy and innovation into the National Forum. So heard a couple of sort of pithy quotes. One from John Clymer, that the National Forum is a disruptive convener, and I love that. The other thing that stood out with us is this notion of bringing strange bedfellows together. So there's a theme here, and what we're thinking is this. You know, when we are, I think each year we are. Continually energized by the amazing work that we hear from our panel speakers, and I think that there are ideas that are in this room that are perhaps nascent, I think is the right word, that require a little bit more incubation, right? But not incubation within our own organizations, but incubating with strange bedfellows, and there are many in this room. And so, when thinking just of a couple of the projects that we have going on at NACDD, I would love to have a conversation with members of the National Forum to talk about these ideas and to help to capitalize on the wealth of knowledge and expertise that we have here. Mm-hmm. So I think we hear it from some of the partners, but then to really be able to just sit down and say, look, I need your help thinking about this. not I need your money, right? But this is thinking about sort of not just not a learning incubator, but a sort of an idea incubator to really get it so that it has stronger legs to stand on.
That's great. Thank you.
And this is William Patterson again. I'm with PCOS Challenge, the National Polycystic Ovary Syndrome Association. So there were a couple of points in which we attempted to tackle this, one from a high level, which I'll let you speak on in a moment, and then also just from a smaller organization from a very practical standpoint. So women with PCOS or polycystic ovary syndrome, they constitute one of the largest groups of women at risk for developing type 2 diabetes as well as cardiovascular disease. And we see some significant opportunities with regard to leveraging the existing models of the members, as well as with regard to awareness prevention, with regard to early detection and intervention. So one of the things to the point of the person who just spoke, I think it would be incredibly valuable for us to be able to leverage some of the models, the resources that people have to be able to reach the population that we have. So we support about 50,000 members, and there are some models such as the FH worksheet for the shared engagement. And I think these are examples of models that we can begin to introduce within our community to really advance the early detection and intervention efforts.
I know a little round robin. But just one thing, and this is an anecdote, a personal anecdote. So I was diagnosed with PCOS and founded PCOS Challenge after my own diagnosis, and working with an insurance company after a physician, one of the first things that you're told is lose weight, come back to see me in 6 months, right? And so as a scientist, I decided to figure out, how do you do that? So nutrition comes to mind, right, as one of the ways to do this. So my insurance company at the time decided that they weren't going to pay for me to see a nutritionist, or they weren't going to approve that, or a registered dietitian, because I wasn't diabetic. So prevention was not a part of the picture there, and I think that this is something that we need to address, and these are stories that we hear time and time again. I just wanted to throw that in there. Mm-hmm.
Could. So first, I want to, my disclaimer, as much as I would never want to agree with a emergency room physician, okay, who might hail from the great state of South Carolina, but actually being a Prev Med guy, something he said really struck me, and that's when he mentioned that their inbox for the insurance company and their lines of effort all went to the quadruple aim.
Oh, did what?
Went to the quadruple aim. So I don't know if you guys picked up on that.
No.
And does everybody here know what the quadruple aim is? Yeah, a lot of people don't know what that is, and that's key. And the reason why I say that, because that's a strategic framework to work from. Okay, it's better care, better health, better cost. Okay, different people say it different ways, but I'm a simple flight doc. Better care, better health, better cost. Okay. But then in the center, which is now the quadruple part of it, used to be the triple aim, came out of HHS, I believe, originally, or CMS. And then, but we added in the military a fourth entity, and then many others did. We put readiness in the middle. Okay, so in other words, why do I want to have better care, better health, better cost? Because I need to underwrite our mission, and our mission is readiness. But then for everybody in this room, that mission is something else. It could be a healthy community if you're a mayor. Okay, if you're an insurance company, it's lower cost. Okay, but the only way you get to lower cost is you got to pull the levers on the other two, on the population health and on the better, so with the better health and the better care. And then if it's for an average family, it's quality of life. If it's a business, okay, it's a healthy workforce. And so I started thinking about that when we start talking about strange bedfellows, of which the strangest would have been the insurance companies, but they got skin in the game, and so I'm wondering if from this group's perspective, you create a strategic framework where you pick a a nationally accepted strategic framework, and then almost everybody in this room is feeding into, or could be, or needs to work those levers with those strange bedfellows. And basically, to me, it's developing a common operating picture for all the players, and then at the end of the day, whatever's in the middle, keeping the end state in mind. And so, I was just thinking up there, just kind of for fun, because that's where I usually sit. But it's a way to look at things and to put everything in perspective, and again, to have your lines of effort. So you're not just, what I call creating, not codependent or not coordinated or not collated, different ways ahead.
I think one possibility we might think of as an orientation of the work of the National Forum 2020 and beyond, with potentially a huge reach, is the concept of arresting the loss of cardiovascular health from childhood into and throughout adulthood. If you look at the first figure in the Losing Ground handout, what you see is a sharp decline in the prevalence of ideal cardiovascular health by age. The earliest reliable enhanced data are in the 12 to 19 age group, about 40% with ideal cardiovascular health, and the age band from 40 to 59 is something under 10%. Now, close your eyes a moment and think about what that picture is. It's a picture of a sharp decline in the prevalence of ideal cardiovascular health with childhood. Abundant data show that ideal cardiovascular health at age 50 confers a long, healthy life of high quality with low medical care costs and compression of morbidity, so-called, fewer years of disability even at the end of a longer life. So a target of preserving ideal cardiovascular health to age 50, say, seems very appealing. So how might we go about that? We've heard in many of the commentaries today about the energy in communities behind improving cardiovascular health, reducing risk of heart disease and stroke, not only in localities, communities, but in health systems, in the military, in other national organizations, the Y and elsewhere. So suppose we were to synergize the activities already underway in these communities under local leadership, local resources, local engagement with supplemental sources of information, technology that permits implementation of perhaps a wider range of interventions to the extent those are acceptable in the community, and better sources of information to evaluate and monitor progress. There's a short paper about this in Circulation, September 4th, and it's called 50 by 50 by 50. Age 50 or older, 50% or better prevalence of ideal cardiovascular health by 2050. Now, could it be higher? Could it be sooner? Maybe. But what we would like to do is to change that curve that's in Figure 1 from a sharp decline in cardiovascular health to no loss of cardiovascular health to age 50, and ultimately increasing the prevalence of ideal cardiovascular health from birth on. So we talked a little at our table about focus. This is a potential focus. There are obviously many other options that we could discuss, but this might be one to keep on the table.
Thank you, Darwin. I think, John, are you ready to go? You ready to go? Okay, great. So thank you, everyone. Please don't forget to leave your papers on the table. Your diagram is now less scary to me. Thank you for explaining it. And thank you all for the brainstorming. I think it was, I hope you enjoyed it. I know I enjoyed it at our table. It's a chance to get different perspectives, thinking all as one on how do you focus our efforts. And that's, again, what the National Forum is all about. So thanks so much, and I'll hand it over to John.
Thank you very much, Laura, and thank you for those great thoughts, great ideas, great recommendations. These may look like simple pieces of paper, but these are extremely valuable assets. So please make sure that you either leave it on your table and we'll pick it up, or that you get it into the hands of Mary Jo at the front desk on your way out, because we really value your thoughts, your ideas, and we want to make sure that we have them, and more than the summaries that were shared here in this session. So thank you for participating, and please make sure you leave these. Everybody knows a lot of people here in your own organizations. You put on meetings that are similar to this, so you know that it doesn't just happen, and unfortunately, I don't think any of us yet have found that right magic wand that we can wave and make it happen. So I'd like for the National Forum team to please stand. Julie, Debbie. And if you're a member, if you participated, Jay and others, on the planning committee for the annual meeting, please stand. Virginia. Come on. Oh, and remain standing. Remain standing. And our team, come on, remain standing. All right, if you spoke today or moderated a session, please stand. You guys are on the committee, stand up. All right. If you or someone from the organization you represent here today is involved in the Value and Access Initiative or the Million Hearts Collaborative and or another initiative through the National Forum, please stand. If you received an award today because your organization is doing great work that carries out the National Public Health Action Plan to prevent heart disease and stroke, please stand. If you serve on the National Forum's Board of Directors, please stand. Everybody, I think this really illustrates that this isn't just putting on a meeting for an audience who come in. Anybody know Hugh Tilson? Does that ring? Yep. So Hugh, if you don't know him, was the public health officer in Multnomah County, Oregon, and then state of North Carolina, and a bunch of other things. Brilliant guy, and he's often called upon to moderate or chair different meetings. And he has this great adage. He said, Washington, D.C. is the most religious town in America. I'm thinking, really? On what basis? He said, the reason I know that, or the way I know it, is because it never fails. At a meeting in Washington, I welcome people, invite their participation, and they all start praying. I was looking around the room this afternoon and this morning at different times during the sessions, and I didn't see anybody on a device. I mean, the attention, the participation was really tremendous, and I think that speaks to the quality of the speakers and the panel members, so thank you all very much again. Thank you to AstraZeneca and Novartis and Sanofi, Regeneron, and the American Heart Association. You can't save the world if you can't pay the rent. Neither can you put on a meeting like this, so thank you for your support. Thank you all very much for your participation and for what you do that makes the National Forum for Heart Disease and Stroke Prevention. We got a lot of great ideas today. We're looking forward to facilitating the execution of them, supporting you in having the conversations, in collaborating, and accelerating your impact. So we look forward to continuing these conversations throughout the year. Thank you.